This conference will now be recorded.
The management of third and fourth degree perineal tears. This is one of the serious complications of labor and delivery. And if it is not diagnosed properly and not repaired properly, then the woman is going to suffer a lot. We use the term OASIS, which means obstetric anal sphincter injuries. And the incidence, it has tripled from 1.8% to 5.9% over like you can say like in 5 years. And the overall incidence is 2.9%, but the range is 0 to 8%. Incidence is higher in the primiparas, which is 6.1%, and in the multipara, it is 1.7%. So basically, as such, the number has not increased, but the identification has increased through proper training and more hands-on skills. We have to differentiate between episiotomy and perineal third and fourth degree perineal tears. Episiotomy is a second degree surgical incision which is given into the perineum. We are basically cutting skin, bulbospongiosis muscle, and then facilitating the delivery of the head, and then it is repaired properly. So there are basically two types of episiotomy: right mediolateral and then central or midline. In Europe, the right mediolateral episiotomy that is preferred because it is associated with less bleeding, and there is no increased risk of injury to the anal sphincter. But it is associated with disfigurement and it can result in sexual dysfunction. And if it is not done properly, then the introitus, it can be disfigured, and then we have to do surgical procedure like Fenton's procedure to fix it. This is for cosmetic reasons, or if the woman is having pains, especially dyspareunia, then we have to do it. Second type of episiotomy is midline episiotomy, which is practiced in USA. That is associated with more blood loss and more higher risk of injury to the obstetric sphincter, but less sexual dysfunction and less disfigurement. So these are the reasons. And what happens sometimes with the passage of the head of the baby, this incision, it can extend, it can involve the anal sphincter complex, and in some cases, it can involve the rectum also. If it is involving the anal sphincter, then we will call it third degree. So basically, classification is simple and it is important for you to understand because in your written exam, in your OSCE, you should expect to see a station on perineal tears. Classification should be very clear, and if there is any doubt that this is a third degree tear or what, then it should be classified to the higher degree rather than going to the lower degree because you are going to give benefit to your patient. So if we talk about the first degree tear, it means that injury to the perineal skin or vaginal mucosa may be involved. Second degree tear, it means injury to perineum involving perineal muscles, but it will not involve the anal sphincter. That is second degree. Third degree tear, it means that perineum has some injury and which has involved anal sphincter complex also. It is further subdivided into three types. Grade 3A, which means that less than 50% of external anal sphincter thickness has been torn. Grade 3B tear means more than 50% of external anal sphincter thickness torn. No, A and B, when your external anal sphincter has been torn. Grade 3C tear, both external anal sphincter and internal anal sphincter, they are torn. In the fourth degree tear, injury to perineum involving anal sphincter complex, which means external anal sphincter, internal anal sphincter, and anorectal mucosa. The lining of the anal canal, it varies along its length due to its embryological origin. The proximal anal canal is lined with rectal mucosa, which has columnar epithelium, because as you know, the whole of the GIT, like from the foregut to the hindgut, all three parts, they are lined by columnar epithelium because the intestine has secretory function also. The distal 1 to 1.5 centimeter of the anal canal, this is derived from urogenital sinus. You know the primitive cloaca, that it will form, then one septum will develop and it will divide the cloaca into the bladder and the future anal canal. So the last 1 to 1.5 centimeter of the anal canal, it is derived from urogenital sinus. So its epithelium is modified squamous epithelium, which is similar to the epithelium of the perineal skin. This is non-keratinized. So they use the word inner epithelium, inner mucosa. You know the innermost lining is called the mucosa. That is the lining and the mucosa. So obstetric anal sphincter injury, it means both third and the fourth degree perineal tears. It is not only about third degree, you should know that, because many students are confused that the fourth degree means rectum has been involved. So that is the point. Then what is anal incontinence? Anal incontinence, it is defined as the complaint of involuntary loss of flatus and or feces affecting quality of life. So you can imagine that the woman, she will be quite miserable if he sustains such injuries. You don't have to remember all of these things because you know these are just the studies. Okay. So, but you should remember that if you are doubtful, that you should classify a tear into 3B or 3A, you will classify that to 3B. A typical exam question is that a woman has sustained third degree perineal tear, which has involved 50% of the external anal sphincter. So what is the degree of how you will classify that? So never classify that as 3A, that is always 3B, because 50% you cannot quantify the degree, right? If they will tell you that just few fibers are torn, that will be 3A, few fibers of the external anal sphincter. But if they tell you that even some thickness of the anal sphincter complex, it has been damaged, then we will say that this is 3A. But when they are categorically telling you that this is 50% of the external sphincter, then you are going to classify that as 3B. That is the point. Okay? Go to the higher degree. Be careful when you have to talk about another isolated tear. You know, this is called rectal buttonhole tear. This tear involves the rectal mucosa with an intact anal sphincter complex. You know, the anal sphincter complex is intact. This is just like a small cut, which may be incomplete. You will just see like there is some bulging and there is some weakness. So you will think that it is better that I should repair it, because even if a small defect is left behind, it can give rise to formation of rectovaginal fistula, which is a far more serious condition and very hard to manage. Then the question arises, can we predict canal, anal sphincter injury? So we should know that there are certain risk factors, and we should be aware that the risk factors, they do not allow the accurate prediction of varices. It's not possible. Okay? But you know, if they ask you that which factor is more closely related, then you should know about a few odds ratios here. Asian ethnicity, here the higher chance of injury. Multiparity, relatively lower risk because the perineum will be lax. Birth weight, if it is greater than 4 kg, yes, it is a significant risk factor. Okay. Then shoulder dystocia, 1.9, it's not very high. Occipito-posterior position, a bit higher risk. If your patient has prolonged second stage of labor, then again you can see that the relative risk is going to increase, and the relative risk will increase as the duration of the second stage will increase. You don't have to remember very petty things, but you should know that the incidence will increase as the duration of the second stage will increase. Like if between 2 and 3 hours, then the chance is there 1.4. Don't remember it. This is just to have a clear concept that as the duration will increase, the chance of having the injury will increase. If the second stage means from full dilatation to expulsion of the baby. If it is between 3 and 4 hours, then again the relative risk increases by a small number. But when the duration of the second stage is more than 4 hours, then the relative risk will increase significantly. Is instrumental delivery associated with a higher chance of having injury? Yes, it is, but with ventouse delivery without episiotomy, less chance. If you are, the chance is 1.8, but if you are doing ventouse delivery with episiotomy, the chance will be very low, like it will become 1/3. Okay, so that's why when we are doing this vacuum extraction, we are giving episiotomy. If you will do it without episiotomy, the chance of having the tear it will increase. You can see that it is almost 4 times. Then forceps delivery without episiotomy, the risk is going to be very, very significant. You can see here it is going to be 6.53. Forceps delivery with episiotomy, the risk will become 1/4. So basically, if you will look at this picture, the odds of having anal sphincter injury are very high. The birth weight is zero point 0.2. Birth weight is more than 4 kg. Then, another significant factor, I didn't like to highlight it before. If your patient she's primipara, then the chance that is the highest risk that she is going to sustain some injury. Okay? Look at this one. So basically, they are going to give you these 3 numbers, that which one is associated with the highest chance of having anal sphincter injury. Nulliparity, that is the most important risk factor. So the problem is that these risk factors, they don't correlate or they don't predict the condition accurately, but they will give you some idea that we should be careful about these things. Okay. So then can we prevent it? So the guideline says that clinicians should explain to the woman that the evidence for the protective effect of episiotomy is conflicting. Medial lateral episiotomy should be considered in instrumental deliveries. Where episiotomy is indicated, the medial lateral technique is recommended with careful attention to ensure that the angle is 60 degrees away from the midline when the perineum is distended. That is also a confusing point. Everyone wants to know that this is the true if the patient is having distended perineum or relaxed perineum. So I have highlighted this point that 60 degrees away from the midline when the perineum is distended. Perineal protection at crowning, it can be protective. So warm compress during second stage of labor, it also reduces the risk of oasis. So episiotomy prevents oasis and anal sphincter injury. The evidence is conflicting. Some say that yes, it does, but actually the effect is there is some protective effect, but when you will translate that into statistical way, that is not significant. Okay. So, but there is some evidence that if we are doing instrumental delivery, then we should do it. Angle of cutting this episiotomy is very important because it is associated with decreasing the risk. Okay. So the angle of 40 to 60 degree is more important than incision angle of 40 to 60 degree. Different people have different things. Okay. So actually it should be 45 to 60 degree away, or if they ask you to choose between 40 and 60, then you are going to click at 60 degree. Okay? You're going to choose that option, I mean. So then the question arises, and then the problem is that here in all of this paragraph they have just written that the problem is that up to 22% of doctors, they were able to perform a true mediolateral episiotomy. Only 13% of the episiotomies, they were at a post-delivery angle of 40 degree. Problem is that doctors, they don't know that what should be the angle at incision. So angle has to be 60 degree from the midline in a distended perineum, not in a relaxed perineum. Okay, because if in a relaxed perineum, it will be way away from the sphincter and it will be like somewhere like in the middle at 9 o'clock position in the vagina. Perineal protection. So perineal, there are two methods like hands poise, where your hands are, these are the ways of supporting the perineum during childbirth. Okay, one is hands-on technique, the second one is hands poised. Hands poised means that your hands are just, both hands are around the perineum, one in the left lower side of the patient and one your left hand on the right side of the patient's perineum, but you are not touching the perineum. You are just ready that if something will happen, you are going to support the perineum. Second technique is hands-on, where your hands are actually on the perineum, like two C shapes. One is C shape on the right side, left side, your left hand, and patient's right side. And the second one will be on the other side, and like the in a sideways image of the C, and you are trying to protect the perineum. Okay, but no difference has been seen that it will have some. There will be much difference. Okay, so some of them they say that what are the things, the hands-on technique, what should be, what happens here is that the left hand, it will slow down the delivery of the head. You can also say it will control the rate of exit of the baby. Right hand will be protecting the perineum. So mother is not pushing when the head is crowning. So you have to talk to the mother that don't push when the head is just crowning. Okay, when we will tell you, only then you should push. Then you have to think about episiotomy if there is a high risk of tear, and then you should remember the correct angle. Okay? So the best method of supporting the perineum, that is unclear. The problem in this area is that we don't know much about it. Then with the resistance maneuver, which means that delivering the fetal head using one hand to pull the fetal chin forward between the maternal anus and the coccyx, and the other hand on the fetal occiput to control speed of delivery. It is not considered better than the standard care. Standard care, it is not specifically defined. Okay. So both techniques can be used and they can be promoted like hands-on and hands poised. What is the effect of warm compresses? So they did some analysis, and what they found that warm compress significantly reduces the incidence of perineal tear in the second stage of labor, of risk of third and fourth degree tear, and the relative risk was, it was 0.48. So it means that you can hold a compress on the perineum continuously during and between contractions. What is the exact mechanism? They don't know. Then regarding perineal massage during the antenatal period and in the second stage of the labor. So, it has been suggested that perineal massage should be done in the last months of the pregnancy, last month of the pregnancy, and also during the second stage of the labor. So, as such, when they carried out this Cochrane review of 4 trials, it showed that perineal massage undertaken by the woman or her partner, it was associated with overall reduction of the trauma requiring suturing. That is the point. Okay. And the number needed to treat it was 15. So it means that to prevent one tear, you should offer this massage in 15 women. And they were also less likely to have an episiotomy, the trials showed. And these findings, they were significant for women without previous vaginal birth only in those who were nulliparous. So then you know why this Cochrane review is important, because they will give you impartial view. So that is the reason. So no differences were seen in the incidence of first or second degree perineal tears or third or fourth degree perineal trauma. So they, in the women, they carried out this study on many women. Okay. Then on the basis of this information, the data showed that the effect of perineal massage in the second stage of labor, they are inconclusive. So why I'm telling you about these things, that in the exam they will show you something and really you will be confused that which one is better in reducing the incidence, like this perineal massage or this mom compresses or what. So actually we don't know about a lot about them. So these are the problems. Okay, so because the incidences they are the same in the different groups. So then how you can identify other risk factors. The risk factors can be according to that all women who are having vaginal delivery, they are at risk of sustaining oasis or isolated rectal buttonhole tears, and therefore they should be examined systematically, including a digital rectal examination to assess the severity of the damage and particularly prior to suturing. So what you have to do, take oral verbal consent, explain to the woman that we suspect that some injury has taken place during birth, and you should offer inhalational analgesia. If you have already given the perineal analgesia in the form of pudendal bark something, then you don't have to do it. But otherwise, for the sake of exam, the recommended one is inhalational analgesia. Ensure that good light is coming from behind you and position the woman so that she is comfortable and so that the genital structures they can be seen clearly without causing any undue stress. So it should be done gently and it may be done in the immediate period following the childbirth. So if the trauma is identified following the birth, then further systematic approach should be carried out. So what you have to do, like we have said, that we should explain that what we are doing and what is the benefit and all of these things. Okay, and then you have to see everything in clearly, and there should be good light. Evacuate the bladder of the patient, see clearly, and then identify the structures that which organs have been involved. And you are just going to do that digital examination, and of course you will do that under anesthesia. If there is extension of episiotomy, then it is anticipated that epidural was already cited. But if it is occurring without any episiotomy, without anything, then you can give her gases, analgesia, nitrous oxide, and then carry out the exploration. Purpose is that your patient should not feel any pain. There are certain principles of repair of oasis. Like repair of the third and the fourth degree tear, it should be conducted by appropriately trained clinician or by a trainee under supervision. So at least senior registrar should be there, and much better if there is third or fourth degree tear, you need to call the consultant. So it should take place in an operating theater, and it should be under general anesthesia with good lighting and appropriate instruments. If there is excessive bleeding, a vaginal pack it should be inserted and the woman should be taken to the theater as soon as possible. Repair in the delivery room, it may be performed in certain circumstances after discussion with a senior obstetrician. So taking to the OR is not absolute, you can do it if you have good experience, patient is cooperative and you are able to see the tear properly. So by the way, how you will know that just by looking at the sphincter that the woman has sustained obstetric anal sphincter injury. I told you the other day, there are puckerings around the anus, right? So if there is tear, third or fourth degree perineal tear, what you are going to see is that the skin around the anal sphincter, it is smooth. No puckering, no folding, nothing, okay? So that is the point. There will be loss of all of these, digitations, and you can get some idea that this patient has sustained some tear. So why under GA? Because the area should be totally relaxed. Okay. So then figure of 8 sutures, they should be avoided because they will cause compression of the blood vessels. They will cause ischemia and the healing, it will be delayed. So a rectal examination, it should be performed after the repair to ensure that the structures, they have not been inadvertently inserted through the anorectal mucosa. And if a suture is identified, then it should be removed. Otherwise, your patient is at risk of having fistula. So if the anorectal mucosa it has been torn, then it should be repaired with sutures using either the continuous or the interrupted technique. If there is a question that which technique should be used to accomplish the repair of the internal anal sphincter, then we know that when the internal anal sphincter it has been torn, it is identified, then it should be repaired separately separately, not along with other structures, okay? With interrupted or mattress sutures without any attempt to overlap the internal anal sphincter. Don't overlap that, you are just going to approximate that. For the external anal sphincter, what can be done? Either an overlapping or an end-to-end, that is just approximation. These methods can be used and they both are going to give you equivalent results. If there are partial thickness tears like 3A and some 3B, then end-to-end technique it should be used. All of these findings, recommendations are based on the studies. Important from the exam viewpoint, they want to ask you that what sort of suture material you are going to use. 3O polygalactin, which is your vital, it should be used to repair the anorectal mucosa as it may cause less irritation and discomfort than the polydioxinin, that is the PDS sutures. So when repair of the external anal sphincter and internal anal sphincter muscle is being performed, then either monofilament sutures such as 3O PDS or modern braided sutures such as 2O polygalactin Vicryl, it can be used with equivalent outcomes. So when oasis repairs they are being performed, then burying of the surgical knot beneath the skin, superficial perineal muscles, it is recommended to minimize the risk of knot and suture migration. So you are going to bury that where? Beneath the superficial perineal muscles. They will be in the superficial perineal pouch. So that's all you need to remember about the materials. Be remember very specific points because you know they have to ask you a certain number of questions, so they cannot go into petty details. Where details are required, I'm going to give you. Then who should repair it? So obviously it should be repaired by someone who has received good training. And for the training, there should be, for training in inner sphincter repair techniques, they should be an essential component of the obstetric training. So actually, you know, many trials they have shown that residual external anal sphincter rate is incidence is 19 to 36%. And one article it said that if you are not sure or if the woman was symptomatic and no tear was diagnosed at the time of delivery, what they did, they carried out MRI on study on them. Then what happened? Almost 80% of the women they had some degree of injury to the anal sphincter and which was not identified at the time of birth. So you have to be careful, okay? Then the question arises that what should be the post-operative management? Of course, you are going to use broad spectrum antibiotics because now the whole of the, you know, this anal mucosa, this anal canal commensals, anaerobes, they are now in, you know, there has been some contamination of the vagina also. So you need to give them broad spectrum antibiotics to control, to prevent post-operative infections as well as wound dehiscence. Then the use of post-operative laxatives, this is recommended to reduce the risk of wound dehiscence. Then bulking agents, they should not be given routinely with laxatives. Just patient should take regular diet, enough fluid, and we don't have to give them like Hispagola, husk or other stuff. There should be local protocols which will tell you that which type of antibiotic should be given, which laxative should be given, like that. Okay? And then women should be advised of physiotherapy. Rather, now the new recommendation is that the woman, such women who have sustained third or fourth degree perineal tears, they should be reviewed by physiotherapists before they have been discharged. Okay, because they are going to benefit if they will start these exercises in the early part of the postpartum period. Then you have to tell them that they should be reviewed at the regular visit. They don't have to come after 2 visits. Just remember that your patient should come back after 6 to 12 weeks postpartum, and they should be seen by, if possible, you have the care, then some surgeon who has interest in the repair of the sphincters, he should see her. And if the woman is still experiencing at 6 to 12 weeks, she's still experiencing incontinence or pain at follow-up, then you have to refer her to the colorectal surgeon. Why? Because the problem in such cases is that you will refer the patient. If you are trying to repair it yourself, and God forbid surgery goes wrong, then your patient will have to have a colostomy and she will have to wait for another 3 months so that all of this granulation tissue will form. Only then she can go for another repair. So that time is of essence and the quality of young women, it will be ruined. I have seen very young women, not only in Europe, I mean Ireland, UK, I have seen in Gulf, I have seen in the Asian countries also. They all will sustain tear and then they will be carrying these colostomy bags for like 3 months. So you can imagine that what will be the mental state of such patient and how much angry she will be. What will be the quality of her life. Regarding prognosis, you have to counsel your patient that 60 to 80% women, they will be totally asymptomatic after 12 months of delivery, 12 months of the repair. So otherwise they can answer this question indirectly that 20 to 40% they will be symptomatic. Yes, that is also true. So then what should be the plan for the future deliveries? So we have to tell them that the mode of delivery should be normal delivery and it should be documented in the notes also. We have to tell them that episiotomy has no role. So it should not be given prophylactically. It should be given only selectively when it is really required. So if the woman who sustained oasis in the previous pregnancy and she continues to be symptomatic, then we have to do an endoanal ultrasound was done and some abnormality was recorded. Then such women, they should have delivery by elective cesarean section. Usually, if they ask you what is the risk of recurrence, then you should remember that the risk of recurrence is going to be high. Some guidelines, some books, they say that it is 1.7%, but that is understatement because actual rate is like 5 to 7%. That is the point. And the most common complication they are going to see, that is going to be the fecal symptoms. That is the problem. And mostly at which time they are going to see these problems? 3 months after the delivery. Risk management is very important. That how risk management is not meant to punish anyone. It means that how you can reduce the risk. Okay, it is for improvement of care provision. So units, they should have their clear protocols for the management of oasis and documentation of the anatomic structures involved, the method of repair, and the suture material used. That should be mentioned. It will be much better if you can keep a pictorial record, so you are not going to take photograph of the perineum of the patient. It can be, medical legal, it can lead to medical legal action against you. You can make simple diagrams. And the woman should be gently and fully informed about the nature of her tear, and she should be offered follow-up, and then you can give her relevant written information also, because it can lead to development of tocophobia. So your patient can develop fear of childbirth. So that's why counseling by some senior person is very, very, very important. And how we can reduce the incidence? By offering them proper advice. Then another important part, consent advice if your patient has sustained third and fourth degree perineal tear. You don't have to remember each and everything. Just remember that very common means that 1 in 1 to 1 in 10, like a person in the family has sustained this problem. Common means 1 in 10 to 1 in 100, like a person in street. Uncommon means 1 in 100 to 1 in 1000, like a person in village. Rare means 1 in 1000 to 1 in 10,000, like a person in a small town. Very rare means less than 1 in 10,000, like a person in a large town. You can write down, you are going to get one question from these 5 lines, so at least you should be sure about one question that will be coming from this information. There is difference between the serious risks and the most frequent risks. Serious risks are those that your patient will have some effects. Okay, patient can have which can be like significant. That's why they are serious. Frequent means that these things are occurring at a higher frequency, higher chance of occurring, but they may be benign. They will not compromise the quality of life of patient and stuff like that. So incontinence of stool and outflatus, this is uncommon. So delivery by C-section in the further pregnancies, it may be recommended if symptoms of incontinence persist or investigation suggests abnormal inner sphincter structure or function. Rare, we said like 1 in 1,000 to 1 in 10,000, that is the hematoma formation. For hematoma formation, you should remember, you don't have to evacuate all hematomas. If the size of hematoma is up to 5 centimeter and the patient is asymptomatic, you don't have to do anything. And just you will examine her in the DR and you will feel the lateral walls. If you can see it, then you will see that how large it is. You are going to assess clinically. If it is occurring just immediately after the birth, then you should open the episiotomy, remove the blood drop, and she is going to be fine. Less than 5 centimeter, actually nothing is going to happen. You can cover her with antibiotics and she is going to be fine. But if it is larger than 5 centimeter and you don't do anything for it, then your patient is going to have spiking fevers, spikes on the temperature record. So she will have like sepsis. So that's why, it would be important to evacuate that hematoma. Smaller hematoma, just give analgesics, like you should give paracetamol, don't give brufen, just give paracetamol and then give antibiotics and observe them. Larger hematomas, counsel the patient, take to the OR, open the episiotomy, drain that, and again cover them for antibiotics and painkillers. And very rare, like maybe in hundreds of thousands, you are going to see like maybe in 100,000, you will see just one case of rectovaginal fistula. So there is a normal communication between the rectum and the vagina, and if your patient, God forbid, it develops it, then you need to refer this patient to the higher centers, preferably to the colorectal surgeon, who is going to fix it. Regarding frequent risks, which are not very serious, but they will be seen in more and more patients. Severe difficulty and discomfort in passing the stools in the immediate postnatal period. Then migraine because of the pain, so you have to ensure that she is getting good pain control, good analgesia. Migration of the suture material which may require removal. Then there can be granulation tissue formation. Sometimes they will ask you that granuloma is formed, has developed at the site of perineal tear. So what type of cells are involved? So the cells involved, they will be giant cells because many macrophages, they will change into epithelioid cells and they will make a granuloma. So, but this one is granulation tissue formation which can persist. They call it episiotomic granulation also, episiotomic granuloma also. 26 out of 100 women. So you can see that this is unfortunately very common. They are going to have fecal urgency. The moment they will have this colorectal reflex, they will just run to the bathroom. Otherwise, they will soil themselves. But there is an important issue. Just mark this point, okay? Sometimes these points are not mentioned in the notes. You have repaired a 3rd degree or 4th degree perineal tear, and patient, it was done like 24 hours ago, okay? And now the patient is telling you that she has soiled her underwear twice. So what has happened? What should be your next action? First one, take her to the OR and open and repair. Second one, write down a serious incident report against the consultant because he has not done it appropriately. Third one, reassure the patient, and if it happens again, like over a period of 3-4 weeks, call her back for assessment. So actually you have to do nothing at all. Just reassure her because we have just done the repair. There was a tear, so some seepage can take place. But if the same thing occurs after 2 weeks, 3 weeks, then it is going to be dangerous and you should do something about it. Perineal pain and dyspareunia, 9%, so this is common. Wound infection, 8%, so common. It may be associated with higher chance of urinary tract infection. When you are taking consent from the patient, when this patient has third or fourth degree perineal tear, you should also ask her about certain things. Like, will she accept blood transfusion if the need arises? If she has any reservations, just record them. Sometimes, if the hemostasis is not achieved, then a vaginal pack is required via for compression so that the bleeding will stop. Then you need to tell the patient that what is this process, what does it involve, what are the risks, is there any alternative treatment, or you should tell them that if we will not do, what will happen. So repair of the third or fourth degree tear, it involves suturing the disrupted structures of the anorectal complex with a slow absorbing, not rapid absorbing, slow absorbing suture material, it should be used. And following completion of the procedure, if disrupted, the vagina, perineal muscles in the skin, they are closed with an absorbable synthetic suture material and an indwelling catheter is inserted because your patient will not know that because because of anesthesia, local anesthesia, your patient will not realize that she has to pass the urine and or she will be hesitant to pass the urine. Antibiotics and the laxatives, they are commonly prescribed for 7 to 10 days, and leaving the third or fourth degree tear is not recommended and it is likely to be associated with increased risk of complications. Then other procedures for which the patient has not consented, these should not be carried out. So preoperative information, you are just going to tell the patient and you are going to fill in the consent form. Anesthesia, this is the job of the anesthetist who is going to see her. So other procedures, they are not recommended at this time. So that is how you will see a consent form. So that is all you need to know about it. So let's go to the other topics. Any question, any problem so far? If there is any question, please let me know about it, okay? So if I ask you one question, why do we do cesarean section? What will you like to tell me? There are just two routes of delivering the baby. We can take the baby out from down below to the vaginal route, or if there is some problem or there is some concern for the mother due to maternal causes or the fetal causes, then we will have to go for an abdominal delivery. So cesarean section is the most common procedure performed in the obstetrics. Major abdominal procedure, and there are certain surgical skills which should be known, and you should know about the difficult cesarean sections like that. So among the difficulties that you can have in the labor and delivery section, that you should know that how you will deal with the third and the fourth degree tears, and you should know that what sort of difficulties you can see when you are doing cesarean section, and then you should be able to do pre and the post-operative management, and then you should know that what is the importance of teamwork. Without teamwork, you can have run into many problems. So all of these are problem issues which are required if you want to offer, they require to be addressed if you want to offer good surgical care. Like when we were talking about the surgical repair of the sphincter, you have seen that how we will do that. And then you should remember that there are certain principles of repair. What exactly are they? So if we talk about the repair principle, it means we have to use universal precautions. What are the universal precautions? You have to keep yourself safe and you have to keep your team safe. Surgical field should be clean. Aseptic technique should be used. Sterile equipment should be used. Choose needle holder, absorbable suture on a curved needle, like it should be like 21G, 4 centimeter diameter, then 4 centimeter radius, then local anesthetic, which is mostly, we have most experience of using 5.5% lignocaine. What lighting should be there? Defined type of the laceration is extent, and it may need to do you may need to do the rectal examination. And once you have done, then it is a matter of common sense that you should remove your gloves and wear another glove. There are certain protective effects like precautions, like you should use minimum amount of suture material, because as you know, there will be inflammatory reaction. So more suture is left behind, more reaction, more adhesion formation, more discomfort, more disfigurement. Then you have to hold the apex of the tear, and you have to go 1 centimeter above the apex of the tear and start suturing from there. Once you have closed, you have to look critically to ensure that hemostasis is there and you have closed the dead space. Why it is important? Because if you will not close it, then tissue is healing. So serosanguinous fluid, it will be coming out and it will be accumulating there, and it will lead to formation of hematoma, formation of seroma, higher chance of infection. Then you should ensure that all of the structures like the hymenal remnants and the fossa, that is the posterior part of the vestibule, they are just in the same line. That is to restore, because you know you are going to restore the original anatomy. Okay? So there should be no disfigurement and no distortion of the sphincter like that. These images are not very good, but they will just tell you that here, like if you can appreciate it. Actually, you know, better idea is that there is a full video. There are many videos. I think I couldn't send the link, so I will be forwarding the link today, because all obstetric emergency procedures are collected in one place. So you will simply go there, have a look at them, and they are just to help you. But they're not our own videos. But these are free resources. Complete disruption. You can appreciate that here. The inner sphincter has been torn. Here, can you appreciate this white line between two areas? This whitish line, right? So still some part of the inner sphincter is intact. Now look at this one. Keyhole appearance, flattening of the folds here, and continuity. Okay, so this is 4th degree because inner mucosa is also gone. Here you can see little mucosa between the two areas. Identify all structures properly. Okay, and then you should know that if you have to suture the mucosa in the running fashion, you can use Rectal 20. Then you have, after closing the inner rectal mucosa, after closing the vaginal mucosa, you need to close the muscles. Some people, they will say that you should, that when that is the routine, but when you have like the 3rd or 4th degree perineal tear, then you are going to repair that tear first. Okay, you have to ensure that area just the mucosa is intact, and then just go and address that issue. Okay? Identify the external inner sphincter and then suture that appropriately. Post procedure, you know that you should, these are precautions. Always make it a point to remove bags, clean perineum. You need to give analgesics, antibiotics, and encourage good perineal hygiene, follow-ups, and you have to write the notes appropriately. Now, what are the surgical principles for cesarean section? There should be a proper indication for the procedure. Informed consent is essential. Pre-operative preparation and care should be made, and you have to talk about the post-operative care. So, any objection, any idea on that about these things? Whenever you are doing any surgical procedure, you need to answer 5 W's. What are you going to do? Why are you going to do it? Where it should be done? Okay. Then what complications you can have? What does it involve? You should know about all details. Then the question is, who is going to do it? Who is also very important. Okay? And then you should plan your surgery. You should know about the indications, about the contraindications. You have to give full information to the patient. So you should have informed consent. Only your patient can give consent for it. Nobody can consent on her behalf. You have to carry out certain pre-operative managements and care, and then you have to offer post-operative care. Broadly, these are the parts of care. Patient should go to the operating theater, which should be antiseptic, and you have to use antiseptics and you have to use aseptic techniques. Pre-operative preparations should be appropriate, like the surgical tool and the material should be there, adequate and the appropriate anesthesia should be there. But this is up to the trial discretion of the anesthetist that he likes to give the spinal or the GA. Incision should be adequate, the place and the type. The most commonly used incision is Joel Cohen, which is given 3 centimeter above the pubic tubercle. So that is the Joel Cohen. Fenton's tail, it is 2 centimeter above the pubic tubercle, but now the recommended technique is Joel Cohen. We should avoid vessels or the visceral injuries, and meticulous steps for hemostasis should be taken from the beginning to the end. Swabs and instrument count should be accurate. Then post-surgically, we need to review and discuss with the patient after surgery. Because if you know, and in the immediate post-CS period, you have to tell the parent, the attendants that how were things, how did they go. So if we look at the incisions, then you can know, you should know. Now we are talking about the uterus. This is the uterus, okay? That we can give different types of incisions. Okay? Like we can give this vertical incision if there is a huge fibroid, or if there is placenta previa, or there are large veins in the lower part of the uterine cavity, uterine wall, uterine surface. Then if the baby is lying transversely, okay. So all of these are indications for classical incision. And if your patient had a previous classical scar, then also in cases of preterm labor, they can be special. So some scenarios, we'll talk about them. Then we can give transverse incisions in the upper segment when the woman has placenta previa, which is lying low, and she doesn't want to have any more cesarean sections, or she has opted for hysterectomy. Then you can open it here also. Sometimes, it is not mentioned here. You must have seen cases where the bladder will be reaching till this point. So just stop, call the urologist, because he will dissect that bladder, which is very high, lying very high against this uterine cavity. Then the surface of the uterus. Then the urologist should come and he should separate the bladder by sharp dissection. Blunt dissection is associated with higher chance of injury. That is the point. Then the lower incision, lower segment cesarean section. When you are doing, then this is the place where you are doing the incision. Okay. Why you have to maintain the size, because if you will go laterally, you are going to damage the right or left uterine artery, which is a large artery, and it can cause severe hemorrhage. So these are the different incisions which you want to give, and you have to deliver the large baby. Okay. So this is that how you can deliver I cannot read it carefully. Okay. So when we are doing this controlled contraction followed by uterine massage, it will reduce the blood supply. So you can see that the pubic tubercle, and then we are trying to remove the placenta. Regarding the skin, when you should suture the subcutaneous layer, you should do subcutaneous suturing if you have more than 2 centimeter of the peritoneal of the fat into the abdominal wall, and you should close it. So, when we are closing the uterus, do we need to close the visceral peritoneum? Don't close visceral or the perineal peritoneum. Why? Because that is not required. These are actually the muscles they are trying to suture. They're telling you that you just have to approximate them. Don't never pull them if there is some injury. Now the challenge of performing the cesarean section, you can see them under certain circumstances. Like, for difficult cesarean sections, what are the considered the difficult cesarean sections? When you are doing a cesarean section at full dilatation, which means second stage cesarean section. When there is infection, because the tissue is, in cases of chorioamnionitis, because the tissue is going to be very soft and friable. So when you will take the suture, she is going to bleed. So such cesarean sections should be done by the consultants, and then we should be ready to use a lot of hemostatic patches. Okay. Then difficult delivery of the child, especially preterm breech baby or transverse baby, preterm or the term. They are very difficult to deliver, so call someone who is more experienced. Then how you will deal with the problems with the bleeding during cesarean section. If you are doing a cesarean section at full dilatation, what precautions should be taken? You are always going to get some questions from the CS on full dilatation. So you should know that it is associated, you need to give a higher uterine incision. Lower incisions means that you will end on the vault or tearing of the lower uterine segment. Then if you have to increase the size because you think that the baby's head is not coming through your incision, then you will go upwards. This is the angle, let's say. Now go upwards, okay? Never extend them laterally. Why? Because in the broad ligament, uterine arteries, they are running and we can cause severe hemorrhage and very hard to control bleeding from the uterine arteries, especially when they are in the, basically they will be in the broad ligament, and in the broad ligament that is just a sheet of the this thickening of the peritoneum, pelvic peritoneum, so they don't have any musculature, so very hard to anchor the uterine arteries against some tissue. When you are doing the second stage cesarean section, then delivery of the fetus can be very difficult, so you can ask someone to help you by putting one hand into the vagina and pushing the head above, or you can use you can try the podalic version where you are holding the baby by the foot and then you are delivering them. If angle tears, then you should be aware of excess bleeding, which need for and the need for good relaxation to secure good hemostasis fast. So arrest the bleeding and then go forward. You should also be very careful about the location of the ureters and what should be done. After obstructed labor, we should catheterize the bladder for 2 weeks to prevent vesicovaginal fistula. If we are doing cesarean section after obstructed labor, then leave the catheter in place for 2 weeks, long period of time, to avoid any stress on the incision and because it will lead to formation of the fistula. Second scenario, if there is infection and you need to do the cesarean section. So exposing the lower uterine segment for adequate incision, it will avoid spilling of the blood or infected material into the abdominal cavity, and it will prevent injury to the viscera. So the abdomen should be washed with normal saline. Saline is the best material because it will not cause death of the living cells. That is the point. Here they are showing you a buttonhole incision. This is an isolated incision that it should be repaired separately. Regarding other difficult cesarean sections, you can see them in cases of transverse lie of the baby. Here, when the back of the baby is up, you should grasp foot of the baby and deliver as breech. When the back of baby is down, then it is going to be a problem. So what you have to do is you will have to do a vertical incision and you will have to give incision down, and then you will go one in. This is the incision down, and then you are giving one incision upward. So you are extending the scar vertically. So a nice incision on the lateral side, and then lower segment incision, and then try to grasp the foot, because basically you have to reach the foot of the feet. That is the problem. So that is when you have to remove the head of the baby. You can use the forceps, and you will use the non-dominant hand. Like if you're a right-handed person, you will do it with your left hand to avoid putting force onto the lower uterine segment, because it will cause more disruption of the place. If your patient has heavy bleeding during cesarean section, the causes can be atonic uterus, placenta previa. So if your patient has atony, no tone in the muscle, like in cases of grand multipara or in cases of twin delivery, then you have the option to offer balloon tamponade, or you can offer V-link sutures. If placenta previa was there, then you can apply compression sutures, ligation of uterine vessels. But first you will do the initial steps. If they are failing, then you will go and do the uterine ligation. If they show you something like this is called rush balloon. But as you know that nowadays we are using battery balloon that is used more commonly. So these are the things. Okay. Now for the B-Lynch. You will do B-Lynch if there is atonic uterus. Many students, they will say that atonic uterus means there is no tone, so what is the benefit of doing it? Still there is benefit. Okay, so you are going to do it with Vicryl 2. 2.0 means very thin, so that is not going to compress it properly. Vicryl 2 means that it is quite thick. In the exam, they like to ask you where you will enter the uterine surface. You can see that the incision is still open, right? So 1.5 centimeter away from the lateral wall, or 1.5 centimeter away from the uterine artery. You will enter here, go to the top, come back from here, go back again and bring the sutures, and then you can tie them. I have seen the doctors in Europe, they will do like this, and then they will take several sutures laterally also. But still, they have not published any such papers, but their technique is also used a lot. So this is how your V-Lynch will appear. You can see that going from here, going to the top, and then coming back, from here, going here, then going up, then coming out, coming from the lateral side, and then tying them in the center. So that's how you're going to continue to apply your base V-Lynch suture. So if the patient had placenta previa, and now the common site of bleeding is the placental site, then what are you going to do? You are going to do the compression sutures in the placental bed. Again, you can use this Vicryl 2, and you are going to take multiple stitches into the base or the base of this placenta, and then after removal of the placenta, you are going to take multiple sutures in the placental bed. Regarding the compression sutures, like in cases of placenta previa, they can be taken from the outside, from here, or even at the back of the uterus. I have seen people doing like up to 30, 40 sutures, they will take them. But it is not done in a continuous way. Just make like figure of 8 and then tie them. That is how you can do that one. If your patient has bleeding and you want to ligate uterine artery, then you should know that uterine artery is running on the lateral surface of the uterine body. Just go there, go over this one, and then tie that. You can tie it, you can go even from through the uterine muscle, and then you'll go around the blood vessel and tie it. Because in the broad ligament there is no tissue, and when you will try to take the suture and then pull that, then you are going to cause more damage into the broad ligament. Like for the broad ligament, they tell you that the shear folds of peritoneum, and they are expanded like the ears of an elephant, like that. So you can see fanning out, or like the ears of an elephant, and here the uterine artery is running, You cannot tie that independently, so you are going to tie it against the uterine muscle. That is the technique. Okay? If you need to ligate the interior division of the uterine artery, you will go above, and you know that is the place where you are going to apply the ligature. You are going to tie be very specific, anterior branch of internal iliac artery. If you will ligate the posterior branch or you will ligate the internal iliac artery trunk, you are going to cause ischemia in the posterior compartment of the leg or of the back of the thigh, and your patient will have severe pain, and you will have to open it because because the alternate routes are there. Collateral blood supply is there, but that is not enough to help your patient. Okay, so you can see here that you are going to just ligate anterior branch of the internal iliac artery. This is a case of ruptured uterus. So how do we repair a ruptured uterus? Remove anything which is inside, identify the structures, identify the ureters, and then we can continue. We'll talk about these in a minute like that. Okay. So the second stage cesarean sections, they are more difficult. So you should know about the surgical skills to repair the perineum, and then second stage CS, and then the hemostatic techniques. Any questions so far? A typical exam question is, in which of the following scenarios you are going to call your consultant? The scenarios are that there is placenta previa, premature baby with a transverse lie, large fibroids occupying the lower pole of the uterus, and then huge varicose veins running on the surface of the anterior surface of the uterus. So in out of these four situations, when are you going to call the consultant? And they gave the option, they never gave the option that in all of these cases you should call the consultant. So what will be your answer? In which of these cases you will call the consultant?
Placenta previa.
Why?
Because placenta previa can lead to hysterectomy. The decisions should, we have to make decisions regarding blood transfusions or the FFPs or platelets. So we need to have a consultant over there.
Yeah, that's correct. I will agree with her, because you know, if there are, thank you for answering the question. So if you have like huge varicosities, doesn't matter at all. Why? You will just cut. You know, basically if there is a blood vessel, you will try to avoid that. But if you cannot, then what you will do? You will try to give the incision if you can give it away from that place. Otherwise, just cut from there. Take the baby out when it is and then give the compression. Okay, once the baby is out, there is a contraction of this more of this uterus. It will be well contracted, and then you take sutures from the place where she is bleeding. So you can do that. If there is transverse lie, then we have seen that if it is back up or back down, then we can take them out in two ways. Back is up, baby can be taken out when you will hold the foot of the baby. Back is low, that is an indication that you should give vertical incision into the body of the uterus, and then you should try to remove the baby. Fibroids as such are not going to cause any risk, and you're not going to do any surgery like myomectomy at this time, because the whole of it, because it is associated with huge losses of this blood. The patient will go into shock. Never do myomectomy along with cesarean section. So it leaves with us that if there is placenta previa, we need to call the consultant, because the patient can bleed to death. So the surgery has to be very neat and clean and should be very quick also. The difficult cesarean sections, there can be maternal factors, there can be fetal factors. Maternal factors, if there are fibroid uterus, if there is previous surgery with extensive adhesions, then if there is poor hemostasis, and then absence of a lower uterine segment, like in cases of preterm babies, preterm cesarean sections, okay, and then placenta previa. So basically, in all of these conditions, you need senior input. Okay? Regarding the fetal factors, there can be breech presentation, there can be twin pregnancy, transverse lie. So all of these are going to be difficult cesarean sections. So prior to the skin disinfection and operative field draping, we have to catheterize the patient. Never, because if you will take the patient without catheter, the chance of bladder injury will be very high. And as you know, two-thirds of the injuries, urological injuries, they are not identified during surgery. So they are identified in the post-op period, and management can be very difficult. Your patient can develop uroperitoneum, can be like no urine output, so you will have to reoperate her. And the fetal, you should be sure about the fetal presenting part. Breech presentation and the transverse fly, they present specific problems. So if you are doing a planned cesarean section, elective cesarean section, then it is better that you should have some information that where exactly is the head of the baby. If there are fibroids, then we know that the fibroids are well known for being very vascular, and then they are even more vascular during pregnancy. Why it is so? Because there are estrogen and progesterone receptors on the surface of the in the cells of myomas, fibroids, and due to the effect of hormones during pregnancy, they can enlarge hugely during pregnancy. That is the problem. Okay, so that's why they will become more symptomatic, they will be more vascular, so that they will cause a problem. And if a fibroid is located near the lower segment at the uterine incision, it becomes potentially life-threatening problem. So what is the procedure if you have such as variance at such an incision? So always aim to do a transverse lower uterine segment incision. But if the fibroid is over the intended incision line, then you should opt for a vertical lower uterine incision, or you can go for a classic cesarean section. Go for this one, lower uterine incision, that is going to be vertical, or that is a classical cesarean section, or you can give like a vertical incision because you don't want to cut through the fibroid. Care must be taken to avoid the actual fibroid, as incisions in the vicinity of the fibroid, it will lead to hemorrhage. If a vertical uterine, lower uterine incision is planned, then there needs to be more extensive dissection of the bladder. Because if the otherwise the bladder can also be involved. So you need to keep the vertical incision within the lower segment. If the incision extends downwards, it may tear through the cervix to the vagina, and possibly the bladder can also be involved. The advantage of this incision is a lower risk of rectal extension into the uterine vessels when you are doing this vertical incision. The classical cesarean section, it has a limited place in the modern obstetrics, and it is only rarely performed when the lower segment of the uterus it has like with a difficult transverse lie, like there is a large fibroid that is obstructing the whole segment, then this may be the only option, then you have to go for it. After delivery of the baby and placenta, the uterus is closed in 2 to 3 layers. Usually with a classical cesarean section, you will take 3 layers. And the muscle wall will be relatively thick, so that's why it needs to be sutured in multiple layers. Serosa is then closed with suture material that would not cause adhesion formation, for example, monocrel, if it is available. Then carefully we should monitor the patient for blood loss, as a fibroid, it can interfere with myometrial contraction. So we should give the patient, you should give one misoprostol, like 200 micrograms should be given during the procedure. And you should tell the anesthetist to give 5 to 10 international units syntocinon. It should be given as a stat dose. And then 10 to 20 units, they can be given in a drip, and they can be given as a continuous infusion. Post-operative administration of 400 microgram of misoprostol, it is also possible. And if you are still thinking that if the uterus is not properly contracted, then you can give another dose, like For a further 1 to 2 dose, you can use the misoprostol, and it depends that what is the amount of vaginal blood loss. So if that is all if you need to know if your patient has a fibroid uterus. Now, if the patient has previous cesarean section or the surgeries were done, like maybe there was endometriosis, we removed that, maybe we did ovarian cystectomy, we did some other procedure, myomectomy was done, and there are extensive adhesions, then you should know that there are going to be unexpected difficulties, and the rule is to expect the worst, to approach the surgery with great caution. What should be the procedure? After the skin and the abdominal fascia they have been opened, then gently approach the rectus sheath. Be very careful with the sheath because the bladder, bowel, or even uterus, it might be adherent. Sometimes the sheath, it might be fibrous and it will not let you go in. But with the caution, but what you can do is you can use the pottery on cutting, you will get through it. So hold the peritoneal rectus sheath with two small clips, and then incise with pottery. If momentum is adherent to the sheath and peritoneum, you should clamp the adhesion, cut and tie it off with vitral or the similar suture material. If bladder is adherent to the sheath and the peritoneal surface, then try to open the peritoneal cavity by cutting, saffold, and the adequate exposure if safely achievable. In the unlikely event of bowel adhesion, gently try to separate the bowel from the adherent tissue by using a racial forceps and fine dissecting scissors. The most important aspect of adhesion is trying to restore normal anatomy as far as possible. So one often has thick fibrous band which will extend from the uterus to the rectus muscle, and those are also tied and cut through in order to secure easy access to the lower uterine segment. This is about the adhesions. You should call the seniors, and then you need to call any other surgeon, vascular surgeon, or even urologist. They should be called. So actually, when you have a patient who has had multiple cesarean sections, you are always alerting the urologist also. He should at least know about your patient. So if there is poor exposure and access to the lower uterine segment is difficult, then it may be necessary to incise the belly of the rectus muscle laterally, and this is safe and easy and it affords excellent exposure. So repair the muscles with interrupted rectal sutures after delivery of the baby. Then another difficult cesarean section you can do is if your patient has a transverse lie, like or in the preterm baby, where the lower uterine segment is not there. By the way, when does the lower uterine segment form?
34 weeks.
Yeah, excellent. 34 weeks, and then it will expand further by 37 weeks. So gradually it will start with
37 weeks.
by 37 weeks. At 37 weeks, you should expect to see the lower segment. So here, when we are talking about absence of a lower segment, usually it means that preterm baby less than 30 weeks and placenta previa or at breech presentation. So these are the problems. Okay, it can be seen, and it can be very difficult cesarean. The procedure is that the safest entry it would be to employ a classical cesarean section, but the problem is, and the benefit of classical cesarean section is that you will get good exposure. Adequate exposure. The most common problem with a classical cesarean section is securing adequate hemostasis, and care should be taken to ensure that the muscle of the uterus is closed properly. Usually 2 to 3 layers of suturing is required. In the exam, you will always see 3-layer repair of the classical uterine incision. And most importantly, one needs to prevent the further formation of adhesions, and thus the serosal layer, it should be closed with a PDS or monotral suture if it is available. Another difficult cesarean section can be if your patient has presented with placenta previa. So this is one of the most difficult cesarean sections as the risk of hemorrhage is high. So the doctor will have access to O negative blood. As a rule, each blood transfusion unit or each blood bank is required by law to keep 5 units of OR negative blood all the time. Otherwise, the blood bank, it cannot work. So if the patient has an anterior placenta previa, try to enter the uterus above the placenta via the lower segment. If this is not possible, make a lower segment uterine incision, and with blunt dissection, you need to use one finger, go through the placenta until you reach the baby. This is extremely nerve-wracking and it can bleed substantially. A better way would be to do a classical uterine incision to avoid damage to the placenta. So one should not be afraid to increase the uterine incision into a J or the T shape, and there is no time to waste in the situations like this, and get the baby out as quickly as possible and clamp the umbilical cord immediately like that. So inverted J shape, inverted T shape, or this is the J shape incision. These are the proper location. Okay. Some people, they will give incision like this, so you, and then they will write down that this was J shape. No, that is inverted T, because in the T you are going to see the upper part and then the joining part. So there in the middle, that is T. If you are extending from the lateral edges, usually it is extended on the left side because that is found to be much better, and that is J shape. Okay. When the placenta previa is posterior, delivery of the baby, it can usually be done via the lower uterine segment. The other problem with placenta previa is that the lower uterine segment, it doesn't contract very well, and the patient is at risk of postpartum hemorrhage, and if the hemostasis is suboptimal. My question is, to begin with, why a person will have placenta previa? Because the surface of the uterus was irregular. Like maybe there was some previous surgery, like DNC was done, then maybe there was some fibroid and uterine artery embolization was done. So after that's why the surface will be irregular, and then the patient, this surface will not undergo contraction, and your patient can bleed a lot. That is the problem. Okay, at the time of cesarean section. Similarly, if your patient has undergone uterine artery embolization, they can ask you that what serious effects you are going to see. So there can be many different serious effects, but you will say that PPH, that is the most adverse outcome at the time of surgery if a patient has undergone uterine artery embolization, because then when this myoma is sloughing off, this fibroid, then that surface will become irregular. Then you should know that when you are trying to restore the hemostasis, then we can use deep figure of 8 stitches, because then the blood vessels, they are running in different directions. Okay, the capillaries can run into the oblique muscles, vertical or horizontal. So figure of 8 is going to compress the blood vessels, so we have to tie off the bleeders. So oxytocin has to be used, and you can give the IV, and then you will use all of the other things like misoprostol in a stepwise manner. And all the colleges, they say that you can use pitocin or carbutocin because it is concentrated oxytocin. If it is available, it should be done. Other things are, you have to remember all the stuff we read about PPH. We can give carboprost, and a contraindication will be that if your patient is asthmatic. So carboprost 25 microgram unit, 25 microgram milligrams, micrograms when you are going to give, and you can give up to 8 doses. That is the way. Okay. So consultant input is essential. Then regarding the fetal factors, when you are doing cesarean section in the case of breech presentation, then it is always wise to ensure the breech presentation is not caused by placenta previa. because if placenta is occupying the lower part of the uterus, uterine cavity, then there can be malpresentation. Okay. Then you know about the steps that what should be done in cases of placenta previa. You read about that. Then the breech delivery, it needs more space and better lower uterine segment exposure. And don't think that the breech deliveries at cesarean sections are easy, because the head, it can get stuck. So there is much more to delivery of the breech baby than merely delivery of the coming head. If necessary, we need to increase exposure of the lower uterine segment by incision of the rectus abdominis muscle. And like we have talked before, that we can cut through the belly of the rectus abdominis muscle. You must have seen that the time of a patient you are cutting them laterally. That is the point. Okay? So to get more area. So open the uterus, draw the incision laterally by digital traction, introduce the right hand and feel for the feet of the baby. Press the feet and firmly draw these downwards. Perform a gentle breech extraction, similar in technique to a conventional vaginal breech delivery, and always keep the baby's back upwards. Close in the conventional way, and you're going to be fine. Now, if there is a twin pregnancy, then you should not assume that twins are small, little babies, and the space and exposure to the lower uterine segment, it needs to be limited. So you're going to give the incision as you will give in a standard case. If the operator finds space and exposure limited, then we need to extend the skin incision. And if the muscle relaxation is insufficient, then we should go and cut the rectus abdominis muscle. The idea of the cesarean section is to deliver a baby gently and swiftly. And if access to the infant is limited, then the delivery, it will be neither gentle nor swift. Bear in mind that after a twin delivery, women are prone to a PPH, so it is prudent to administer 1 or 2 misoprostol tablets orally or rectally to contract the uterus and prevent blood loss. Now, if you have to do cesarean section for a transverse lie, so when a transverse lie is encountered, it is possible to deliver via transverse skin incision. Procedure is that if the obstetrician is inexperienced, then it is prudent to consider delivery through a midline sub-umbilical skin incision. And good free access to the lower uterine segment is important. And if this is limited and more space is thought necessary, then cut the rectus muscle with scissors from the median margin laterally, as this will increase exposure markedly. Once in the abdomen, review the fetal lie by gentle uterine palpation and manipulation. If the uterus is relaxed with plenty of liquor, it may be feasible to coax like head or a breech into the longitudinal position. Beware of the large caliber vessels which will be coursing over the lower segment. These may indicate a placenta previa, and they should be tied off with 20 Vicryl or monocryl, it should be used, which is 30 sutures. So incise and displace the uterine peritoneum. You can use the Russian forceps or Mayo scissors. Have forceps or a vacuum extractor ready to deliver the fetal head. You can use the kiwi also, because basically it was developed to deliver for delivery of the head at the time of cesarean section. Commence well wall suction to keep the operating field clear of the fluids, and gently incise the lower uterine segment. Open the final few millimeters with Mayo scissor, or digitally you can do that, and manually feel for the fetal presenting part. If a head is felt, call for fundal pressure and deliver either with Wrigley's forceps or by vacuum extraction. If you feel feet of the baby, seize these and perform gentle breech extraction, keeping the fetal back uppermost. If a cord, hand or the shoulder emerges, Pop these back and feel for the feet. Don't try to pull them out with the hands. You cannot do that. It will be extremely difficult. If you feel only the fetal back, then remove your hand, straighten the baby into a longitudinal lie, reintroduce your hand, and deliver the baby. If you open the lower uterine segment and find a placenta previa, proceed as we do in cases of placenta previa. Close in the usual manner. If the rectus abdominis muscle was cut, close the muscle with a hemostatic repair using a few figure of 8 stitches. And leftovers from the uterine closure, they are the excellent suture material for this purpose. So any question, any problem for you so far? From the operations, you are going to get several questions, okay? You're going to get OSCE station also because you have to talk about these things. So know your sutures, what type of incision, what precautions. So it was basically just a summary. If you will go and read the full operations in such scenarios, it will take you like the long hours, like maybe 10 hours, but this much information is enough to answer all questions on difficult surgical procedures. Do you have any questions so far?
No.
So if you are taking consent from a patient for cesarean section, what would you like to tell her?
We will tell her about the uh, risk of having the repeat LSCS. We can
Okay,
tell her about the risk of having placenta previa and accreta with subsequent C-sections. We
okay.
can also tell her about the risk of having the blood transfusion. She
Mm-hmm.
underwent into hemorrhage. We
Okay.
can also tell her about the risk of the fetal risk regarding the respiratory distress syndrome and
Okay.
uh, that's it.
Yeah, these are the important points. That whenever you're talking about the cesarean section, you need to tell them that what is the chance that they can face any problem. So in the
Uh, uh,
cesarean
the,
section
uh, the,
again,
the, the injuries to the viscera also, like for example, the bladder injury or the bowel injury, we can also discuss it with them.
yeah, you have to discuss them. Actually, thank you very much. Whenever you are talking about the consents, like I've told you guys before, that you don't need to remember each and everything. Just remember the 3, 4 most common issues, and then that's enough to answer the questions. Okay. So again, so when we are doing cesarean section, like all surgical procedures, we will have certain serious risks and certain maternal risks. Serious risks and frequent risks, and the risks are going to be maternal and fetal. So if the mother is undergoing cesarean section, she can go for emergency hysterectomy in 7 to 8 women in every 1,000. So this is uncommon, okay? Less likely, okay? The need for further surgery or need to return to the OR, that is 5 women in every 1,000. Again, uncommon. Admission to the intensive care therapy unit, that is 9 women in every 1,000. The chance of developing thromboembolic disease, that is 4 to 16 women in every 10,000 women. So this is rare. Risk of bladder injury, 1 in 1,000. Rare. Risk of having ureteric injury, 3 women in every 10,000. So that is also rare. Risk of death, 1 in 12,000. So that is very rare. Regarding her future pregnancies, increased risk of uterine rupture during subsequent pregnancies, like deliveries, then 2 to 7 women in every 1,000. So this is uncommon. Increased risk of antepartum stillbirth, 1 to 4 women in every 1,000. Again, uncommon. Increased risk in subsequent pregnancies of placenta previa and placenta accreta, 4 to 8 women in every 1,000. Again, this is uncommon. Regarding frequent risks, you should know that there are maternal risks and the fetal risks. Maternal risks, frequent risks that which are occurring at a much higher frequency, but they are not posing any risk, any threat to the life of mother. Like in the maternal issues, persistent wound and abdominal discomfort in the first few months after surgery. So 9 women in every 100. So this is common. Increased risk of repeat cesarean section when vaginal delivery is attempted in a subsequent pregnancy. So 1 woman in every 4. So this is very common. Readmission to hospital, 5 women in every 100. Hemorrhage, 5 women in every 1,000. Infection, 6 women in every 100. The fetal issues, lacerations, mostly scalp lacerations, and the incidence is 1 to 2 babies in every 100. So that is common. So if the baby sustains some cut, then you should remember that you will counsel them that these things do happen and it is not going to cause any other problem. So it doesn't need suturing because just by giving the compression, she is going to be fine. So that's all you need to remember about the cesarean section. We can have a special scenario when your patient has placenta previa and you are going for cesarean section. Again, you need to tell them about the patient about serious risks and the most frequent risks. Risk of emergency hysterectomy up to 11 in 100, which is very common. Need for further laparotomy during recovery from the cesarean, that is 75 women in 1,000. Chance of thromboembolic disease up to 3 in 100. Then bladder or ureteric injury up to 6 in 100. Future placenta previa 23 in 1,000 women. Massive obstetric hemorrhage 21 in 100 women. So this is very common when you're doing cesarean section for placenta previa. In women with placenta previa and previous cesarean scar, the risk of emergency hysterectomy is going to be 27 in 100 women. So this is for one who has placenta previa and previous section, the chance is 27 in 100. Otherwise, emergency hysterectomy is up to 11 in 100 when she doesn't have any previous surgery. But now with the previous surgery, you can see her risk is going to be more than double. 11 into 2 is 22, then plus 5. So 225% increase in the risk of 240% increase in the risk of having hysterectomy. In a woman with an abnormally adherent placenta, that is placenta accreta, the woman should be advised that hysterectomy is highly likely. And if the placenta is found to be abnormally adherent to the wall of the uterus, it may be safer to leave the placenta inside the uterus or to perform a planned caesarean hysterectomy to avoid heavy bleeding than to attempt removal. Excessive bleeding, it may require blood transfusion and other procedures including emergency hysterectomy to control the bleeding and to as a life-saving measure. Admission to a critical care unit, it may be then necessary. The most frequent risks of cesarean section with placenta previa include maternal and the fetal issues. For mother, admission to the intensive care unit, high chance. Okay? Risk of infections, yes, higher. Risk of blood transfusion, very high. For about the fetal complications, baby will need to go to the neonatal intensive care. Then that is the risk. Okay. Then we have to tell the woman that if any extra procedure will be required when we are doing cesarean section for placenta previa, so we need to tell her that there can be damage to the bowel or the bladder or the blood vessels. Then we will have to call the colorectal surgeon, urologist, or vascular surgeon. Specifically, where the placenta previa accreta is suspected owing to the combination of the placenta previa and previous cesarean section and or imaging information, then discussion concerning the following should take place. You should ask the patient what is her opinion about the cell salvage. Just tell her that when there is bleeding from your own tissue, this blood will be collected in special bags. It will go through one filter and then this blood, it will be, transfused back into the body. The problem is that there is a small risk of transmission of infection and transfusion reactions. They are associated with use of donated blood. These problems can be avoided. But there is a theoretical risk of maternal sensitization to the baby's blood, and rarely it can cause amniotic fluid embolism. So they have not, these are just speculations or hypotheses, and they have not been confirmed by research. Interventional radiology, yes, this will occlude the uterine blood vessels by cannulation of the femoral artery under X-ray screening. So foam plugs, balloons, or coils, they are passed through these cannula to block the vessels and control bleeding. Either temporarily they can be inserted or they can be placed permanently. The risks of this intervention should be discussed with the woman by their radiologist in advance. Then what the procedure is likely to involve and the benefits and risks of any available alternative treatments. So including no treatment, then you should know that the procedure is likely to involve delivery of the baby or the babies and placenta through an open approach using abdominal incision and incision into the uterus. Both incisions are usually transverse, and the abdominal and the uterine incision both are transverse. And if either a midline abdominal incision or a classic uterine incision is being considered, the woman must be informed of the reasons and the added risks. So sometimes forceps are used to deliver the head of the baby, especially with breech presentation. So the reason for cesarean section, it must be clearly discussed and documented, as must the great risk with the mother and the baby of not performing the cesarean section. Informed consent, competent pregnant woman, she may choose no treatment options, like she may refuse cesarean section, even when this would be detrimental to her own health or the well-being of the fetus. In such situation, every attempt must be taken to ensure the woman and her birth partner will realize the critical importance of a cesarean section in this specific decision. So you will do everything. If they agree, well and good. If they don't agree, then you will just proceed with the stuff you are doing. You will leave her alone and you will say that you are going to respect the decision of the patient. That is called autonomy. Okay, regarding B-lane suture, we have talked about it before that this incision is very important. Again, I will just like to show you the pictures. That is how you're going to take the suture. You will enter like 1.5 centimeter lateral to the wall, go up, come there. Then you are coming anteriorly, going here, going posteriorly, and then you can come there. Okay? So that is how you're going to, then you are going to tie all of this structure. So that's what you're going to see. Sutures around the body of the uterus. Then bringing them out together and tying them. And after carrying out this procedure, we can repair the uterine incision. Don't repair it first and then do that. That is the tip. So this B Lynch, this person, he presented this Dr. Lynch, he published his paper and he said that he has found they have done many such procedures and they found it to be very helpful. So there is a traditional B-Lynch suture where the abdomen has to be open and hysterectomy incision has to be made on the uterus so as to access the uterine cavity. Like hysterectomy is done, like your patient has delivered vaginally, so you know that B-Lynch you cannot apply from down below. So you will have to open the uterus, you will have to open the tummy and then you will go and apply this suture. Hysterectomy may be required. That is opening up of the uterus. What are the prerequisites? Place patient in the Lloyd Davis position or supine for a cesarean section, and the abdomen is open. A transverse lower segment hysterectomy incision is made in the uterus, just like for a cesarean section, after reflecting the bladder and peritoneum inferiorly. Or now the newer evidence shows that you don't have to push the bladder down. Okay, so both techniques are acceptable. Or previous cystectomy incision is open, hysterectomy incision is open, then the uterine cavity is evacuated of any retained products of conception. Then an experienced assistant by manually it will compress the uterus and swab vagina and examine to see if the bleeding abates. If bleeding stops, then V-Lynch suture, it is likely to help and one can proceed with the procedure. What equipment do you need? A rapidly absorbable suture material like Vicryl or foamic catgut, or you know that we don't use foamic catgut anymore, or we can use other monofilaments like Vicryl can be used. Big hand needle like the 70 centimeter diameter needle should be used. 30 centimeter needle or a needle driver, it can also be used. And these things are easily available in the ORs. Single person is there, you know that in out technique, in out technique is used through 6 points. We have seen that we will go through the 6 points. How are they 6 points? One point where you entered, then the second point where they re-entered, then the third point when they went up, first point, then they went up. See, can you appreciate first, second, back, third, fourth point, then came back, fifth point, and that is the 6th point. So you are going to suture 5. Anyhow, they are not going to ask you that how you are going to introduce it. So then you are going to tie all of this stuff in front and she is going to be fine. So yeah, I was saying 1.5 centimeters. Sorry, I confused two things. Uterine artery is lying 1.5 centimeter below the uterine artery in the lateral corner. Okay, I confused that one with this 3 centimeter. Please correct it. I'm correcting myself. We will have to go inside 3 centimeter below and 3 centimeter lateral to the lateral 3 centimeter below and 3 centimeter medial to the lateral border of the uterus. You are going into the uterine cavity and then you are coming out again at the same distance, and then you are going to the other points, and then you are going to take it out, and then you are going to tie it. Okay. Then that's all you need to do for her, and you don't have to do like many other things. Okay, this in out and out in technique, that is the best one to serve your purpose. That is the point. So it is this technique, it was associated with a significant reduction in the chance of having other complications like proceeding for hysterectomy. So V-Lynch is quite effective. Just remember 3 centimeter lateral to the medial border and the point of incision cavity, 3 centimeter below that. That is the ideal point from where you can take incision. Any other question, any other problem right now? Okay. Last week we were talking about the instrumental delivery and stuff, and this topic is very important. That's why, you know, it keeps coming up and up again and again. So you know about the indications and the stuff. So I will. So basically, what are we doing in the assisted vaginal delivery? Forceps and the ventouse delivery, they will make up assisted vaginal delivery. So we do it for to avoid having a second stage cesarean section because that is associated with more complications. Indications can be maternal or indications can be fetal. Maternal indications are that if she has medical disorders that require shortening of the second stage of the labor, like the cardiac disease, grade 3, class 3 or class 4. Then if she has severe hypertensive conditions or she has respiratory conditions, these are the maternal indications. When she has some illness, then maternal exhaustion, previous cesarean section, which is a relative indication, and then undue prolongation of the second stage of the labor. So in cases of regional anesthesia, an extra hour is allowed and provided both mother and fetal condition is satisfactory. Then you can continue without offering the instrumental delivery. Fetal indications include fetal distress, prematurity, Like the forceps, they provide a protective frame and ensure good control over delivery of the soft head. Now you know that vacuum can also be applied if the period of gestation is up to 32 weeks. Don't apply vacuum if the period of gestation is less than 32 weeks, otherwise you can apply it. Then in cases of breech presentation, who are going for assisted vaginal delivery, then you can apply the instruments for the delivery of the aftercoming head. Malposition, it can be corrected. Like ventouse delivery, it may facilitate rotation and delivery of the malposition such as occipito-posterior position, occipito-transverse, and acentalism. Acentalism, when the sagittal suture is not in the middle, it is closer to the pubic symphysis or it is closer to the sacrum. Regarding classification of the delivery, you know that outlet, mid-pelvic, and then the high forceps. Outlet or the low forceps delivery, where the fetal head it is not palpable abdominally, and sagittal suture is in anterior posterior diameter, and the fetal head is at the perineum. Mid-pelvic forceps delivery, when the fetal head is 1/5 palpable abdominally, and position of the fetal head, it may vary from anterior posterior to transverse, and the station is at 0 to +2. Then high forceps delivery is applied when the fetal head is not engaged and cesarean section is safer in that one. So high forceps delivery is not indicated. So the types of forceps are
In
more
new
than
guideline,
6.
we don't have high forceps delivery, na?
Yeah, no,
We
we don't have. In the new
uh,
classification, we don't have. This is the older
we don't have.
classification.
Yeah.
But this is why this point is here, because first of all, this is based on the old guidelines, and then the second thing is that sometimes they will ask you in the exam that high forceps. So by high, people think that it is +1. No, high means that the head is not engaged, so it should not be delivered instrumentally, and it is better to go for cesarean section. So high doesn't mean that it is at 0 or +1. That will be mid cavity. Beyond +2, it will be low cavity. Okay, that is the point. Outlet, low cavity. So more than 600 types of forceps, but four of them, they are most commonly used. Wrigley's, they are the outlet or the low forceps. Then at the time of cesarean section, ideally we can use that. These Wrigley's, they can be used at the time of cesarean section also. You must have seen that. Then Neville Barnes, they are used the mid pelvic and the outlet forceps. Then Piper forceps. So Piper's forceps, it is used for after coming head of the breech. That is more specific. Everyone will say that we can apply Neville band for the after coming head of the breech. So Piper forceps you are going to use after coming head of the breech. Many books have mentioned Neville bands. Actually, you can use Neville bands also, but recommended one are Pipers. Then Killen forceps. Killen forceps you are going to use for the rotational forceps. All rotational these deliveries, instrumental deliveries, should be conducted inside OR. Even non-rotational between +1 and +2, they should be conducted inside OR because they are associated with higher chance of failure, so should be carried out in the OR, where you can immediately have a recourse to cesarean section. There are certain prerequisites for forceps delivery, like informed consent from the patient, experienced operator should be present, adequate analgesia should be available, like local infiltration should be there, or regional analgesia should be there. Bladder should be empty, episiotomy should be done, because we have seen that if you do instrumental delivery without episiotomy, the risk of having injury to the perineum will be 4 times higher than with the episiotomy. Membranes must be ruptured. Cervix must be fully dilated. Adequate uterine contractions should be there. Head must be engaged at or below spines. No evidence of CPD. Sagittal suture should be in the anterior posterior diameter. What preparations should be done? Consult patient about the procedure. Prepare the necessary equipment. Assemble the forceps prior to application. Ensure that the parts they fit together and they lock well. Don't pull without locking them. Then cover the blades of the forceps with antiseptic cream and gel. So sometimes they can just give you the pictures, the forceps. This is Digley's forceps, the one with the flatter and the longer curves with the handle and shank that is Neville Barnes, and one with the two curves, pelvic and the cephalic curves, and the sliding lock that is Gilland forceps. Procedure is that patient should preferably be in the lithotomy position, ensure adequate analgesia, determine the exact position and station of the fetal head. Why? Because you are trying to ensure that it meets the above mentioned criteria for delivery of the baby. Clean and drape the patient, employ aseptic measures for the rest of the procedure, and episiotomy should be cut, and it should be like at 60 degrees from the distended perineum. With the left hand, hold the blade of the forceps vertically over the patient pubis. So first forceps you are going to apply with the left hand. So if it is your left hand, then what should be the side of the baby? On what side of the maternal pelvis you will insert it? Think about it, okay? Insert fingers of the right hand into the vagina alongside the fetal head and slide the left blade of the forceps between the fetal head and hand, rotating it to rest in a horizontal position. So you are going first, you are going to, if you are a right-handed person, you are going to apply the left blade and you are going to apply on the left side of the patient. Okay, that is the point. Repeat the same maneuver on the other side, using the right hand to insert the right blade of the forceps between the fetal head and the left hand. Depress the handles and lock the forceps. Difficulty locking the forceps, it implies either incorrect application or incorrect position of the fetal head. Force should never be applied to lock the forceps, but rather remove the blades, confirm the correct position of the fetal head, and reapply only if easily possible. Once the blades are locked, apply steady traction in a horizontal and the posterior direction with each contraction. The fetal heart and the correct positioning of the forceps, they should be checked between contractions. There should be a descent of the fetal head with each pull, and only 2 or 3 pulls they should be necessary to achieve the delivery of the fetal head. Once the head is delivered, disengage the forceps by removing the right blade first, followed by the left. Perform active management of the third stage of labor to deliver the placenta and repair the episiotomy, and check the perineum thoroughly for any additional tears. What should you do if you have the failed forceps delivery? Forceps delivery, it should be classified as failed if there is no descent of the fetal head with each pull, or the fetus remains undelivered after either 3 pulls or after 30 minutes. In the event of a failed forceps delivery, you should go for a cesarean section. Complications of the forceps delivery include maternal-like trauma, perineal, vaginal, cervical lacerations, hematoma, bladder and urethral injury. Even bladder can be ruptured. There can be rectal injury. Then there can be hemorrhage because of the tears, supine atony, higher chance of infection, neurological injuries for the baby, like for the mother, like drop foot. Drop foot, you know that it will occur due to damage to the common perineal nerve.
Common perineal.
Yes, thank you. Long-term pelvic floor prolapse can be there, and incontinence and the fistula formation. Problems for the baby: death, neurological injuries, intracranial hemorrhage, facial nerve palsy, paralysis, brachial plexus injury, trauma, skull fracture, damage to the facial bones, lacerations and bruising, and then transmission of HIV if the mother is positive. For ventouse delivery, the prerequisites: cooperative mother, and she must be having uterine contractions, and they should be strong, because in vacuum you need maternal effort also. In cases of vacuum, episiotomy is not always essential, but in forceps delivery, yes, it is essential. It can be used for malpositions such as occipital transverse, occipital posterior, and asymptotism. Contraindications: preterm fetus, now if less than 32 weeks. Face and breech presentation: fetal head is not engaged, and possible bleeding tendency of the fetus, fetal distress. All of these are relative contraindications. Regarding preparations, the same, that equipment should be ready, it should be working, and the connections should be fine, and testing the vacuum on a gloved hand, that can it exert this suction or it cannot. Then cover the cup of the vacuum with aseptic cream gel. Procedure is the patient should be in the lithotomy or the lateral position. Ensure adequate analgesia. So where are you going to put the gel? Inside the cup or outside the cup?
Okay, can you repeat the question?
Where are we putting the gel? Inside cup or over the cup? Cup of the vacuum. Okay, think about it. Okay. So
Inside the cup.
yeah, the patient should be in the lithotomy or the lateral position. Ensure adequate analgesia. Clean and drape the patient and employ aseptic measures for the rest of the procedure. Determine the exact position and employ aseptic measures for the rest of the procedure. Determine the exact position of the fetal head, identifying the posterior fontanelle. Between how you will identify, because you are going to see triangular figure, triangular defect in the posterior part of the scalp. Between contractions, pass the largest possible cup through the introitus and place it on the fetal head with the center of the cup over the posterior fontanelle. Confirm correct application of the vacuum and that no maternal soft tissue is caught within the rim of the cup. Ask the assistant to activate the pump, creating a vacuum of 0.2 kg per cubic centimeter. Again, check applications of the cup, ensuring that no maternal tissue has been drawn under the rim. Have the assistant increase vacuum by 0.8 kg per cubic centimeter. Once the maximum power has been established with contraction, commence traction in the line of the pelvic axis and perpendicular to the cup. Place the gloved hand on the fetal scalp next to the scalp to assess for the descent of the fetal head and potential slippage of the cup during traction. Only pull during contractions. The fetal heart rate should be monitored continuously and the correct application of the cup should be confirmed between contractions. Support the perineum during the delivery of the fetal head. As soon as the fetal head has been delivered, release the vacuum, remove the cup, complete the delivery of the baby, perform active management of the third stage of the labor, repair the episiotomy if performed, and check the birth canal for any additional trauma. When you will see that the vacuum extraction has failed, if there is no descent of the fetal head with each pull, the fetus remains undelivered after 3 pulls or after 30 minutes, or the cup slips off the head twice with correct application and maximum negative pressure. In the event of a failed vacuum, cesarean section must be performed. Again, what are the complications, maternal and the fetal? For mother, there can be trauma to the birth canal and with the forceps delivery, but less hemorrhage. Secondary trauma, there can be uterine atony. The fetus can have scalp injury, bruising, abrasion, laceration, caphal hematoma, subgaleal hematoma, intracranial hemorrhage, retinal hemorrhage, neonatal jaundice, and transmission of HIV infection. All of these are complications of the surgical procedures. See, that is the sagittal suture. You are applying first on the left side of the, this is right side of the head, but left side of the maternal pelvis. See, you can see the blade going inside. then you will bring it vertically, okay, and then you can flip it into, rotate it into the position. So put your hand between the fetal head and the maternal pelvis, and then apply the instrument. Insert it, and then you are going to lock them together. You can see here that you are checking that the lock is at the proper place. Then that is the correct application, okay, and you can see the marks there also, and that should be the direction of the forceps. That is the point of vacuum. Vacuum is applied 3 centimeter anterior to the posterior fontanelle, and the center of the cup should be at the level of the posterior fontanelle. They can use the elastic plastic cup, but associated with higher chance of failure.